Hi everybody, welcome to part 3 of Understanding Cardiac Surgery for Nurses. And this is a brief learn shop, and it really just discusses post-operative points that might be important for you to consider. So we look at the post-operative considerations, chest tube drainage and underwater seal drainage, epicardial pacing wires, sternal wiring and dressings, the ICU admission, and ventricular assist devices such as intra-aortic balloon, pump counterpulsation. Now, post-operative cardiac considerations consist of chest tube insertion and the drainage collection systems. Now, thoracic and mediastinal drains are inserted after cardiac surgery to ensure that fluid and air drain from the chest cavity. And this is to reduce cardiac and respiratory complications related to abnormal accumulation of air and fluids. And typically, because it will vary depending on the surgeon, you'll have a pleural tube that can be in the apex, which drains air. You've got the basal tube, which drains fluid. Then you've got the mediastinal, which is the base, which typically will drain air and blood, or at the apex, draining blood. You don't want to get a pericardial effusion. You don't want to get a pneumothorax. You don't want to get a hemothorax. You don't want to get a pleural effusion, which could happen. So, pleural drains typically are placed at the apex and at the base. Apex typically drains air in the upright position. Pleural, the base, drains blood in the upright position. When you look at pericardial chest tubes, which can be mediastinal, as far as terminology goes, they drain blood. Mediastinal chest tubes drain blood as well, because you don't want to end up with a pericardial tamponade, and certainly not an effusion. Drainage collection systems. Thoracic drains are typically connected to underwater seal drainage systems, or they can be connected to RediVacs, which are typically mediastinal and pericardial, and these are controlled manually. Then you've got epicardial pacing wire implantation. Now, temporary epicardial wires are typically placed on the heart to meet unforeseen complications like bradyarrhythmias, bradycardia, heart block situations, or even asystole. Routine use, however, in the literature is unnecessary, as the need for pacing prior to chest closure identifies patients who will require postoperative pacing. However, in my career, patients have come back quite stable to the post-cardiac surgical ICU, and they didn't have epicardial pacing wires in, and they did go into a bradydysrhythmia unexpectedly. So this is how they look, and this is how they would look coming out of a patient's abdomen. Atrial epicardial pacing wires, ventricular epicardial pacing wires. However, some surgeons are often concerned with removal, because if you remove them, you've got to pull them out of the heart, and this could potentially cause bleeding, which could cause a pericardial effusion or tamponade. Atrial epicardial pacing wires, ventricular epicardial pacing wires. Then you've got sternotomy. Now the wiring, sternum wires are important, and they're used to rejoin the sternum after open chest surgery. They're made of stainless steel or titanium, and they're used to hold the sternum together after open chest surgery until healed, which usually takes the same as most bones, 8 to 10 weeks. Here are certain examples of different techniques that can be employed, different types of equipment, which are numerous, and typically this is how they look on chest x-ray. they're radio-opaque, the wires. Now, skin closure and dressings. Typically, however, standard gauze dressings are applied to most sternotomy wound incisions after cardiac surgery before leaving the operating room, and they're typically left there for 48 or 72 hours, depending on the unit policy. Hydrocolloid dressings are not ideal for wounds that require regular assessing, as it can be difficult to assess the wound as far as drainage, moisture, infection, and so on. As I said, the dressing will typically be removed after 48 hours after surgery. Transparent dressings can be used to visualise, and that way you can see fluid accumulation as well. But typically, standard gauze dressings are the ones that are recommended. They absorb moisture. They can be visualised fairly easily when blood or whatever fluid, plasma, seepage, can be coming through the dressing. So we see skin closure, which is with suture material, or staples, depends on the surgeon preference. A gauze dressing is typically applied. Sternotomy, skin closure, and dressing. After which, the patient is transferred to a cardiac surgical intensive care unit. And following any cardiac surgery, all patients are transferred to the cardiac surgical ICU or an ICU or a critical care unit for about 1 to 3 days. It depends on the procedure and the postoperative clinical status of the patient. However, a person undergoing open heart surgery will usually stay in the hospital itself for about 7 to 10 days. 1 to 3 days in the ICU. Thereafter, probably a high dependency unit. Thereafter, probably a cardiac ward. And the purpose of being transferred to the cardiac intensive care unit is to continue invasive hemodynamic monitoring, because you'll be receiving vasoactive medications, fluid support, especially if your hemodynamics are unstable. And these can include blood products, epinephrine, dopamine, dobutamine, norepinephrine, vasopressin, prostaglandin E2, glycerol trinitrate, nitroprusside, and even nitric oxide, depending on whether you're a pediatric or an adult and what condition you are in. Also, in the intensive care, you may require post-cardiac surgery to provide intra-aortic balloon pump counterpulsation, left ventricular assist device support, right ventricular assist device support, or biventricular assist device assist. Typically, biventricular assist, right ventricular and left ventricular assist is in pediatric cardiac surgery, intra-aortic balloon counterpulsation more so in adults, but all can apply. If you're interested in intra-aortic balloon counterpulsation, look at the intra-aortic balloon counterpulsation learn shot. It's pretty straightforward, and you'll probably learn something if you don't know about intra-aortic balloon counterpulsation. Remembering that intra-aortic balloon counterpulsation is the most commonly used device for mechanical circulatory support in ICU following cardiac surgery. Intra-aortic balloon counterpulsation basically reduces left ventricular afterload, makes it easier for the heart to empty, reduces myocardial oxygen consumption, improves myocardial perfusion, and promotes coronary blood flow. So it's important in coronary artery bypass graft surgery, and it may be used prophylactically. So let's review. Can you name the coronary arteries? Again. right coronary artery, left coronary artery, circumflex coronary artery off the LAD. Then you've got marginal branches and diagonal branches. In the right coronary artery, you can also have the posterior descending artery. Label the following structures in your mind, which are blank in the following diagram. 1, 2, 3, 4, 5, 6. Aorta, pulmonary artery, left atrium, right ventricle, left ventricle. Identify and name the 4 cardiac valves. Nothing hard. You've got the pulmonic, aortic, mitral, and tricuspid valves. Mitral, bicuspid, 2 cusps. Tricuspid, 3 cusps. Aortic and pulmonic, 3 leaflets. Aortic connected to the sinuses of Valsalva, coronary arteries under normal circumstances. Name the typical arterial harvesting graft sites for coronary artery bypass surgery. They are the rema, right internal mammary artery, the lima, left internal mammary artery, and the radial artery. Name the typical venous harvesting graft sites for coronary bypass surgery. They are, correct, a lesser and greater saphenous vein, but remember the basilic and cephalic can be used as well, but less commonly. Name the common designs of mechanical cardiac valves using the following diagram. The common designs are the swivel tilting disc design and the ball and cage design. Then you've got common types of biosynthetic cardiac valves, and they are typically animal or from a different species, which are allografts and xenografts. Can you name the vascular defect? Look at the aorta and the corrective surgery in the following diagrams. The defect is coarctation of the aorta, and this corrective surgery is end-to-end anastomosis. Can you name the cardiac defect and the corrective surgery in the following diagrams? The defect is in the ventricles, ventricular septal defect, and it's patched. Patch closure with either some sort of synthetic material, Dacron, or biological pericardium. Depends on the size. Can you now name any medications, 4 medications, that a patient may require postoperatively in the cardiac surgical ICU? They are possibly epinephrine, dopamine, dobutamine, norepinephrine, vasopressin, prostaglandin, glycerol trinitrate, nitroprusside, and most certainly oxygen. Thanks. That's the end of the Understanding Cardiac Surgery for Nurses Learn Shops. Check out any of the other Dr. Manny Learn Shops on YouTube, and please, if you find them of any benefit to you, please recommend them to your colleagues. Subscribe if you choose to, and remember, Dr. Manny Learn Shops are essentially for you.